Venky always gives me subjects that you can easily cover in 7 minutes. And so we'll try to stay on board and try to have a little fun. So when do I use stents? I use them when I have flow-limiting dissections, when I have inadequate angioplasty results, when I have perforations, and in aneurysms sometimes when we're treating popliteal aneurysms, which types we'll speak about and why, and I suspect this will be self-explanatory. So I commonly use different kinds of stents. So first off, we have the nitinol tubular metal, and I predominantly only use these in the proximal SFA. You can place these accurately in the proximal SFA. You're not as apt to fracture a stent. Medicated stents, we have Alluvia and Zilver. They're clearly the best outcomes in terms of the nitinol tubular stents, but they're expensive, and a lot of programs, there's no extra compensants for that, and so a lot of times they're not used. And finally, non-medicated, we have many, many options here, and I think some of them are better than others. Nonetheless, that's where we use those. Now, what about wire interwoven nitinol, the Supera stent? I use these in calcific lesions as they have profound radial force, and I use these in the popliteal segment. These are very fracture resistant. They have high radial force to resist compression. However, they're much, much, much more technically dependent. You have to understand how to use these if you want a good result. You have to prep the vessel ideally, and I'll show you some of the tools that we use with that. And then I use covered stents. I use these in popliteal aneurysms, cases of long in-stent restenosis, because there's good randomized control data there, and perforations. And right now we have self-expanding. We have Viabond and Covera. These are self-expanding stents that I sometimes use in these areas. Now, as Sonia showed you earlier, this is a very complex environment, and that leads to problems such as stent fractures. When David Ali and I published the very first article on stent fractures in the SFA, we got hate mail. People were saying, you're trying to ruin this field. And no, we weren't. We were trying to point out a real problem. And these just speak about some of the problems. Suboptimal resistance to compression, limited stent flexibility, recoil or under expansion, kinking when you bend the leg, and poor long-term patency. Here you see a case of a stent that looked pretty good by angiography. And you hear me keep wiggling over there when people say we've got a great result, we haven't reanalyzed it by IVUS. This happens sometimes. This looked like a beautiful angiogram. But look at this stent compression, and it just doesn't have enough resistance. So the Supera stent, and I was on the board of Supera. I was very involved and helped to create the mechanism to deploy this. It's a nitinol interwoven stent, and it maintains a really nice lumen if you prep the vessel right and put it in right. If not, you have a nightmare in a vessel. But this resists kinking. You can see this patient with his leg bent tremendously. This stent does not kink. And this has been used a lot. And the results, when used right, are pretty spectacular. 3-year freedom from revascularization was 94%, and that held true even in very long lesions and calcific lesions. However, these aren't always placed so well. But look here when you have nominal deployment. Nominal deployment means a stent that was intended to be 10 centimeters long comes out 10 centimeters. And no more than 12 centimeters in length. If that happens, results are great. However, sometimes these come out twice as long as the intended length, and then you lose the radial force, you lose that geometric arc, which is what creates the radial force here, and you lose some of the flexibility. And where people have had problems with these, they put them in wrong. Now, what about stent fractures? These simply don't fracture. I have been sent cases where fractures did occur, and I've seen them in 3 cases. 2 of those where people had placed them in popliteal entrapment syndrome and had tried to go in after and open them up with cutting atherectomy, and who knows which caused the fracture. And I saw one other, I don't remember what happened, but there were multiple, again, atherectomies performed, and that was in the whole, things, people would send me these as they saw them. Now, one thing that's important, if we get this stent in and it's the right length end to end, and even if it looks jammed up right at time 0, look at what happens over time. It normalizes itself. But if this stent comes out very elongated, it never straightens itself out because it gets bound and it cannot come back to its normal length, and you lose some of the fight here. So what are the keys here? if you're going to put this in, you better predilate. Predilate to the outer dimension of the stent. These new dimensions, they've changed from how it used to be when IDEV had it to now with the FDA's genius guidance. Now they give you a number that's neither the inside or the outside diameter of the stent. It is 2.78 millimeters smaller than the outside diameter of the stent, which you have to go to. You need to size this 1-to-1 in a vessel. Very, very important, not oversized. And unlike other stents where you may put the stent in and post-dilate after, the majority of your work is done before you put the stent in. And when you do this, if you want to get a good result, get maximum magnification and watch the geometry of your stent. It's coming out cone-shaped as you do this, and you're adjusting that on the fly as you do it. Now, what about the Gore-Viabahn study? I'm just going to show you one thing. This is for long in-stent occlusions. And this was a study that was created. There were 100 patients enrolled here. And this was one-to-one randomization of using Viabahn versus standard of care, which at that moment was balloon angioplasty and treating in-stent restenosis. It showed much, much better outcomes because you were excluding some of the plaque, you were making a big lumen. And of course, the bigger issue was what happens at the ends. As you've heard many people say, with covered stents, the stent itself, which is biologically inert, really is not where the recurrence occurs. It's always the end. Now, so evidence here showed clearly superior primary patency, and they're about 3 times less likely to require revascularization, and they were very low with serious adverse events. Now, if you're going to use these, use them right. Avoid excessive oversizing. Critically important. Treat all of the disease, because the ends are where you have problems. Prescribe appropriate antiplatelet therapy. Assure adequate inflow and outflow. If you put these in and you don't have at least one strong outflow vessel, expect problems. Place the device at the SFA origin if disease is present there. Overlap devices if you need more than one by at least 1 centimeter because these can move a bit. Post-dilate because you have to iron out that wrinkly PTFE. Do not use angioplasty outside the device that's oversized and may injure that area and set up a nidus for restenosis. Use regular duplex ultrasonography, and if you see a high-grade recurrent lesion, fix it because the next thing is going to be clot, and treat progressive disease. Don't wait for this. This is just a nice example of a patient long in-stent occlusion, and this is post-Viabahn, and a pretty predictable thing. Stents are a critical part of vascular interventional medicine, and strides are being made to prevent elastic recoil, to exclude plaque, to seal perforations and aneurysms, to apply drugs, and in some cases, be bioabsorbable. But you know, and this was all for SFA, by the way. That's why I didn't have anything about the bioabsorbables. I'm actually now the chief medical officer of a company that's just gotten approved for a amniotic membrane covered stent for bronchial lesions, not for the legs, not for the legs. But I am sure curious, as you might imagine, as a vascular guy, to see where might that play a role in the future too. So there's a lot. Stents are not static. Stents are moving as well, and stents are not a sin. Stents, particularly stents that don't break, and by the way, most fractures you can't see unless they're horribly displaced. I suspect a lot of the problems that we've seen long-term with stents are bad. I now have some patients that are more than 10 years post-Supero that were deployed right that are still widely patent. And so I think it remains to be seen where stents ultimately evolve. I don't think they're a sin. Thank you.
Thank you.